We're going to go to a second phase now that we have completed the treatment prosthesis, which was also our radiographic guide, okay? And that radiographic guide allowed us to make a CAT scan so that we could virtually place these mini plants. Well, that's been done. And you've had 2 months of healing, and I'm going to check in your mouth in a few minutes if we can continue to make a permanent prosthesis that has attachments in it, okay? And it will be very, very similar to this prosthesis that you have as far as bite, looks, except it will have permanent attachments in it that will be a little bit more stable than this treatment partial that has a soft liner in it only, okay? So let me do this right now. Let me take a look in your mouth in just a couple seconds here. I got a glove up and everything. You can see it comes out, but it's still pretty hard to come out. You can see that you still have your gutta percha marks in there from our CAT scan, because this was our radiographic guide. And everything's okay. You can see here we still have that soft liner with the 4 little ball attachments into the soft liner. And it's just about ready to change because the soft liner is kind of going by the way of getting old. But it served its purpose. Now, when we're done with our complete permanent prosthesis, I will take the gutta percha out of these holes here and fill them with acrylic or composite, and this will become sort of a spare for you, a spare denture for you. Now, let me take a look at your mouth, and they're doing quite well, thank you. So a little sore spot right there, and I can adjust that this morning after we're done with our initial impressions. You may have a little overextension of your border right here in the anterior section, but other than that, it looks pretty darn good, pink and stippled. And obviously brush these like they were your own teeth really, really well, 2 or 3 times a day.
Oh, right.
And what we're going to be doing, we're going to be making impressions of this lower ridge with the 4 implants this morning with some alginate impression material. We call that irreversible hydrocolloid. And that will allow us to make a custom tray. And Tricia, my right-hand person, is going to be doing it, okay?
Okay.
Very good. She will also make impressions of your upper complete prosthesis, okay, today, saving it for when we have to place teeth in the wax and make sure the occlusion is good. Here we go. And close just a little. It's more accurate if the jaw is slightly closed because the mandible flexes when you open wide from the muscles of mastication. So whenever you make any kind of impression, you want to close enough to keep the thumb in the mouth, but not open real wide. It's not accurate enough. Once irreversible hydrocolloid is set in the mouth, you need to wait 1 more minute for accuracy to be perfect. But then this material needs to be poured up immediately with improved gypsum stone. Right here, her tongue kind of gets in the way, and we can't do a whole lot about it with this stock tray. But what we'll do with the custom tray is have some length here when I border mold it next time, and it will be able to get her underneath her tongue or around her tongue. And then in the custom tray, we'll also have an area where the holes are, where those implants are, and sticking up. The ball is sticking up out of place. But everything looks pretty good. We got the retromolar pads. We're going to try the upper tray in for your opposing cast. That's it. Molding it slightly. Although the important part of this are the teeth. May come out with it. Yeah. Sometimes the denture comes out with it, which is just fine. That's a good thing. Take it out, and I'll clean it up and put it in as you pour it up. I'll put the treatment prosthesis in, make sure it fits. And what I'm going to do is adjust that little sore spot there, right here, on the inside. And I'll do that adjustment. And all I'm going to do is adjust the soft liner that's bothering her a little bit. I can see where it's at. Basically in the lingual flange area, what I tried to do with this prosthesis was to get the soft liner to grab a hold of that lingual flange and this concavity here. Very important with someone who can tolerate and has a lateral throat form that can tolerate this length of a lingual flange. The anatomy is doable, and this holds nicely. It just didn't hold here, see? And that's why we put in the 4 SDIs, or mini plants. And soft liners are easy to adjust. Very user-friendly material. Because they have a little alcohol base in it, a little silicone base, they're also keeps the bacterial count down. But they can stain because they're not as hard as your acrylic, your Lucitone 199 acrylic. And as you can see here, we've made some room for that area where she had a little sore spot. Still keeping this depression right here that we need to hold on to that prosthesis. And that should be better. That tap, tap, tap. Good. Bilateral balancing occlusion is so important, even in your treatment prosthesis. That should feel better. Does it feel better?
Yes.
Good. Don't forget our precepts of occlusion. When you have complete dentures, they need to be bilaterally balanced so that the denture does not flop around and move when chewing occurs and that Posselt envelope of chewing motion occurs. Good. Tap, tap. Go side to side. Good. No movement. Good. Great. Very good. So next time we will be making impressions with a tray that kind of looks like this. We will be border molding first with material that forms to the length of your vestibule, or how deep your jaw goes down here with the sides of your muscles, the buccinator muscles and so on, okay? And the mentalis muscles, as well as the tongue and everything, the lateral throat form, the mylohyoid muscle has to come up. We're going to do everything in a dynamic process so that the border molding, just like we did on the treatment prosthesis, the border molding will be very accurate. Good morning, Joyce. How are you today?
Just fine.
Good, good. You remember the last appointment we made initial impressions of your lower jaw. And what we did with those impressions was to make a custom tray. And I'm going to show one of those custom trays to you right now. So what we're going to do first is we're going to do a polyvinyl siloxane impression material. And that means that we're going to have on top of your implants impression copings that we can take them out. Okay? It's very accurate. Now, before we make impressions with this custom tray, we have to make sure that your borders are really accurate. Okay? It's very important so that we have really good suction even without the implants. Okay? It's very important that we actually make a denture that almost doesn't need the implants and the attachments inside. So we do that by border molding, and what I use is I use heated Adaptol, and we go ahead and line that half at a time, and your mouth border molds it. I'll make you go through some movement so that your muscles move and create a border. Check the implants. Oh, they're very clean. You're doing a good job. That one right over here, maybe a little bit more. What's unique about these is that the abutment is actually attached to the implant, so it's a single direct kind of implant with its own abutment, which means we don't have any gap problems or any micro leakage. And just want to make sure that's clean. We'll place the impression copings onto the implant with the abutment, and they should snap on nicely. There we go. And that snaps right on, and I do that for the other three as well. This, with the snapping action, it really makes it accurate. They're not going to move until we remove the impression from the mouth, and they'll go in to the impression. Okay, Joyce, I'm going to try this in with the impression copings in to make sure we have plenty of room for the impression copings without hitting the tray. As you can see here, we have stops for the distal extension, so we make sure that the impression material doesn't get pushed into the tray itself, in only maybe the two areas that there are some stops, some distal stops. So I'm going to try this in. It's very important to use a mouth mirror, and the reason being is that on one side, the distal extension of the impression tray can be used for one side, and then the other side, the mirror is used, so that the custom tray can go into the mouth very easily. And it goes in pretty nicely. So what we'll do now is go on over to the warm water bath. So what we have here is we have a warm water bath at about 120 to 125 degrees, and you can see the Adaptol is in here warming up nicely. Sometimes they leak, but I like Adaptol. It's very accurate, and it's very quick. We also have ice, a bowl of ice and water, so that once this gets taken out of the mouth, we put it in ice water, and that makes sure that the Adaptol isn't going to move. So we take the Adaptol we have here, which I really like, and we basically border mold one side, or half an arch. Sometimes we place it back into the warm water bath so that this warms up, so that Joyce's muscles of mastication in her movement, that I'd make her in movement, will go ahead and form the border mold. And I'll place the mouth mirror on this side. The distal extension will take care of that side, and then we place it in her mouth. What I do is, Joyce, go ahead and close. Open, lick your lips, move your jaw back and forth, and go ahead and lick your lips again. Good. And what that allows is it allows the digastrics and the mylohyoids to move, as well as the buccinator muscle and the masseters to create a border. Immediately what I do is go ahead and dump it into the ice water. Air dry. And then go ahead and place the second half onto the custom tray. And it's that easy. Give it a few seconds to not be too warm. And then warm it up in the water bath again, making sure it's nice and soft, but not too soft, obviously. And then this goes directly back in the mouth. Make sure that you use the tray on one side to act as a mouth mirror, And the other side that has the soft material, you use the mirror so that it doesn't get moved. And again, close your mouth. Good. Stick your tongue out, open wide. Stick your tongue up high. That's it. Now go back and forth. That's it. That makes the movements perfect. So again, you have your mylohyoid and digastric muscles that deal with the lingual flange. And then you also have the buccinator muscle and the masseter muscle to help border mold the area. Then I take it out. And you can see we have a nice molded area. Now you can see right in this area where the tongue is and the frenum might need to be adjusted a little bit, which is fine. We'll do that. Also an area right here that's a little overextended on the tray. We go ahead and take that off, and then we go ahead and warm it up again and do it again. So I will go ahead and relieve the areas of the tray that are a little overextended. Only a couple areas. And place, it's only really one side that needs to be heated up again in the warm water bath. You never want both sides heated at the same time because that material will then move as you try to get it into the mouth. Move that over where I relieved the custom tray, and then we go right back into the mouth. Notice again the distal extension of the impression tray, the custom tray goes on the left side, and then I use the mouth mirror on the right side and go ahead and go through your movements again. Close your mouth, open real wide, lick your lips. Good. Go left and right. Good. And purse your lips again. That's it. Open. Very good. This time, as you can see, all the material has gone over all of the borders of the custom tray. So what we do now is we put it in ice water for about a minute. We then take a sharp barred Parker and we scrape away the intaglio surface or the impression surface of the Adaptol border mold, because our impression material will make this more accurate. We don't change the length, just the internal surface. This is an important concept because this area has been relieved for impression material, and you don't want the excess to be into the impression. Now you have to make sure your barred Parker is sharp so that it doesn't tear away the border molding that you've just done. It just gets rid of the inside. If you have a dull barred Parker, it will actually chip away the whole border mold, and of course then you'll have to redo it a bit in that area, which I've done. As you can see, we pretty much have a pretty clean area here. A few little spots that we need to clean up. Now after I've done that, again, I'll put it in the ice water to make sure it's still very hard, and it should be. Adaptol in room temperature conditions doesn't really get soft anymore, but it's always nice to do that. And then what I do is dry it off, and then I have my assistant Tricia paint the inside or the intaglio surface, making sure it's dry first. But also she's going to make sure that the adhesive goes over the border where we have the Adaptol. Notice how she places the adhesive not only inside but on top of the Adaptol so that the impression material will stick and create an accurate border as well as the intaglio surface or impression surface. Now, after we've placed the adhesive material for the polyvinyl siloxane, you must wait 7 minutes. The research in the literature shows 7 minutes to get it tacky enough so that the polyvinyl siloxane material will adhere to the custom tray. What we'll be using today is polyvinyl siloxane, and we use a light-bodied material. I cut the tip a bit because we don't want to take forever to put this light-bodied material around the bottom of the implant. We want to make sure that, and you want to move this way, we want to make sure that we don't put any of the light-bodied material over the undercut areas of the impression copings because they need to come out within the impression. I'm going to go ahead and press down these impression copings so that I make sure that they're nice and tight and very accurate. Remember, they clicked in. The analogs, as you can see here, are exactly the same as the implant abutment, the one-piece implant and abutment, and they will clip in to these impression copings, which are going to be in the impression material. And they click right in. It's very accurate. You don't have to mess around with splinting them all together. Open for me. Just like this. And Trisha's going to tell me, my assistant, when she's almost done, because I don't want to start putting in this material until she's basically done, because the material will start setting up in a warm mouth. Remember, it's been cut, so it's very quick that this will be mixed.
Almost there.
And Trish just said she's almost there, so we're going to go ahead and put this material in. Notice I put it in and I bury the tip the whole time. That makes sure that we do not have any voids or air bubbles. Open wide. Good. Now, Joyce, go ahead and purse your lips. That's it. Open wide. Go ahead and lick your lip with your tongue. Great. Now go ahead and go back and forth with your jaw. And now just close a little. Good. Because that's actually more accurate if the mandible is in a flaccid position, then it won't flex in. And we hold it for 4 minutes. Okay, Joyce, I'm going to take the impression out now very carefully. And with it will come the 4 impression copings. See, here's your implants, which are fine. And this is pretty much a perfect impression. Now this can be poured up by the laboratory technologist at the lab, Glidewell Lab, and they will also place the analogs that will click in to those impression copings. You don't have to do that. If you're going to pour up your impression in-house in the office, then you can go ahead and place your analogs, and they click in. Very positive seat. Lingual flange material here. All the borders were adhered to. You can see retromolar pads were taken into consideration. Obviously, this is a very important anatomic landmark because they do not move within the life of the person. Good morning, Joyce. How are you today?
Just fine.
Good. Since we have made really, really nice master impressions of your lower jaw with your implants involved, we are now able to take some registration records from an occlusion rim. And I'm going to show you that right now, okay? What we have here is we have some wax that are on occlusion rims. And inside of the occlusion rims, we actually have a couple attachments on either end here that are placed for stability so that it's not rattling around when we're taking our bite registration and vertical dimension of occlusion and teeth selection. Okay?
Okay.
You can see it kind of Pops right on, and we'll be doing that today. Starting with our vertical dimension of occlusion, which we have already calculated by the lower existing denture that I made, the treatment denture, and that will allow us to get a good record of your vertical dimension. It's very important because we don't want your teeth in the way of speaking and chewing. Okay? So that's what we're going to start with first, is getting our vertical dimension of occlusion. Okay, Joyce, what we're going to do now is evaluate your vertical dimension of occlusion. Because you have some existing treatment dentures that we already evaluated our vertical dimension of occlusion, we're going to go by this a little bit. But just to make sure, do me a favor and lick your lips and say 66.
66.
Say Mississippi.
Mississippi.
Very good. So what we're going to do is we're going to put a few red marks on you. Don't worry, you won't look like Bozo.
Okay.
And I'm going to have you lick your lips and just close with your teeth as well. Stay real still. And we're going to measure this. Now I want you to do that again. Lick your lips and close. And the key is this repeatable? Lick your lips and close. Your teeth are together. That's pretty good. That's the way I like it. Now do me a favor, and when you close next time, keep your teeth apart. Lick your lips, say Mississippi,
Mississippi,
and just close your lips and relax. And you can see we have about 1 millimeter to 2 millimeter freeway space or rest position. Go ahead and lick your lips and completely close. Bite down with your teeth. There we go. You notice how I don't coerce or guide or anything too much, because when you do that, then they start doing things that aren't natural. And go ahead and lick your lips again. Say Mississippi.
Mississippi.
And this time just close your lips. And this is pretty repeatable. Now it's very important to save this guide here by pushing this little lever down, and this position, this measurement does not move. So we put this to the side for just a minute. Very safe place. Joyce, I'm going to be taking out your treatment denture right now, okay? Which also doubles as our radiographic guide. And placing this humongous occlusion rim with all the wax and everything. And I'm sure it's going to be too big, but that is standard. Yeah, I know. There, now it's clicked on. Bite down for me. Just relax your lip. Getting back to my trusty guide. Tricia, you can come on around. Just relax your lip. I'm sure it's way too much. And it is. You can see we're about 5 millimeters open. So what we do is we take a wax spatula, a plain spatula, and we go ahead, open for me, and take some of this material down. It'll be a lot easier next time. Okay, we heat the wax plain spatula. And in a very gentle way, we go ahead and carefully take some of the wax away from the occlusion rim, like so. Try not to take too much off because then you have to add wax and that makes it more difficult. So what we do is try this into the mouth again before I take too much off. And I'll be putting the cuts into the occlusion rim so that the impression, the bite material, the registration material will set properly back onto the occlusion rim. Joyce, I'm going to try this back in. It won't be quite as big, but it'll still be fairly big. Always use a mouth mirror. It's very important so that you don't hurt the patient when you're putting in a prosthesis that is as big as this. There we go, got it. Sorry. There we go, got it. Much better. Bite down. Good, just like that. And just barely close your lip, just like that, perfect. Trusty Bowley gauge again. We'll see how far we've got. We're darn close. It's just about 1 millimeter off, but let's make sure. Lick your lip and bite down again. About 1 millimeter off. Now go ahead and lick your lip again and bite down. What I do every time is make sure the lip is flaccid. Just relax, that's it. But bite down, that's it. That mentalis muscle can change. So it's just a little over 1 millimeter. Open for me. I'm going to get this baby out again. We'll go ahead and heat the spatula again, making sure our plane of occlusion is equal to the maxillary denture that has already been made. Now we have this just about right. I'm going to try it in again though. But I think what I'll do is take the barred Parker, make the occlusion rim notches so that our bite registration material will go right back on. Thanks, Tricia. In the right position. And it's always good to put them in 2 different directions on either side. Then you know your bite registration material is back onto the occlusion rim. As far as the maxillary denture, there are teeth involved there right now because we already made her maxillary denture before her implants were placed because we needed to know where those implants needed to be placed via the occlusion. If you were to make a new maxillary denture, you would have occlusion rims for the maxilla as well. Again, use your mouth mirror so that you don't hurt the patient if you can. We have long lingual extensions here, so we have to be very careful on how these go in. I think I did it right that time, didn't I? Mm-hmm. Bite down. Good. Keep closing. And relax your lip. Okay, lick your lips and close. Just like that. Right on. So we're in good shape with our vertical dimension. Go ahead and lick your lips again. We'll try that one more time. And bite down. Very good. I like that. It's repeatable. Everything's good. You can see that we're going to duplicate the midline of the maxillary denture. So we really don't need to put a midline mark on the mandibular denture. That would actually maybe get the lab technologist a little confused. So we just tell them to make sure the midline is the same as the maxillary midline. If you were to have an occlusion rim on the maxilla, You would have to make a correct plane of occlusion with the Frankfurt plane from the ala of the nose to the tragus of the ear, and then make the maxilla equal to that, and the length, since she has a low lip line, we would have a little longer maxillary occlusion rim. Then we place the midline on the maxillary occlusion rim. In this case, our midline is going to be the maxillary midline. Open for me. Good. Stay right there. Place a thin bit of material here. Do not close yet. And what I do is I kind of romance the mandible a bit. Good. And start closing. That's it. Start closing. Good. And bite down. Firmly. That's it. Just like that. Okay, Joyce, I'm going to have you open. Thank you. And that's good that it sticks to the maxillary denture, like so. And I'll give you the maxillary denture back very quickly. And you can see what we have here. We have a nice bite registration with the teeth in place at the correct vertical dimension of occlusion. Okay, we have her existing upper denture, maxillary denture. We also have her treatment lower denture. And so we kind of know what shade we're going to use, and we're going to go with the 102. We just want to verify it. And that's pretty darn close. That's what we want for the lower, for the mandibular. And you can go ahead and put this, I'll put it back in for you, Joyce. Treatment denture still fits right over those implants and the ball. So the shade, you can write this down, Tricia, is 102. Tooth selection will basically be the same as her existing denture, so we'll need a model of that too, an impression of that, as well as the maxillary denture, so that they can set up the teeth. Now with her existing treatment denture, we can make sure what mold we want on the posterior teeth, and you can measure that just to verify it with your Bowley gauge at about 32. Now many times I will only place 3 teeth in the posterior area, but we're going to go with 4, just like the maxillary prosthesis for her. But a lot of times we will do 1 bicuspid 2 molars, or 2 bicuspids or premolars and 1 molar, so that we don't have a real deep distal extension. But in Joyce's case, we do want our retromolar pads to be covered. That gives us a nice permanent stop in the posterior area, and the 4 implants in front give us a stop in the anterior area, as well as a dislodging deterrent. We are going to make impressions of the existing treatment denture as well as the maxillary denture. We're basically going to duplicate it, and we want to let the laboratory technologist know exactly how we want to duplicate it, because we've done it already. This is sort of a trial run for the radiographic guide. Now our next appointment, Joyce, will be trying in the denture, okay, the lower denture, with the teeth in wax, so that we can do any adjustments that we want to do at that time, and make sure you like it, make sure our vertical dimension of occlusion is really good, and make sure our occlusion is very good, okay? Mm-hmm. We made the treatment prosthesis, which also doubled as the radiographic guide, exactly how we wanted Joyce's teeth to be. We tried them in, we had lots of try-ins, aesthetic try-ins, phonetic try-ins, vertical dimension. So, Joyce, go ahead and close for me. We want to create what we've created in the beginning, which is sort of like, it actually is a class 2 occlusion here. This creates a better aesthetic requirement for her, because that's what her jaw was like when she was younger, although it has moved out since she's lost and resorbed bone. The jaw itself doesn't move out, but the position of the bone is a little bit farther out. So what we have to do is recreate her class 2 occlusion, and this is what we have here. Bite down. So what do I want to make sure of, open for me, is that the permanent prosthesis that we will be fabricating, and right here you can see it's on an adjustable articulator in wax. We want to create that same kind of situation if we can. So we'll try it in. And what's kind of cool about this is that we're able to, with these 4 implants in the tissue model here, we're able to place 2 attachments in here, which aren't permanent yet, because they are actually in the occlusion rim. And we try it in the mouth. So as I try this in the mouth, what's kind of cool is that I already have a guide from her existing treatment prosthesis. Bite down. Open. Make sure it's in there. Yeah, it is. Close for me. Good. And as you can see, it's just a little bit, bite down, it's a little bit more forward than I would like. And what that'll do is create sort of a lower lip that's a little too pouty. I call it the George Washington dollar look. You know? So we're going to go ahead, and since we tried this in today and it's in wax, we're going to go ahead and reset the teeth to where they'll be in a class 2 or more lingual position. Bite down, and you can see that there is a difference. It isn't tremendous, and it's more so on her left sort of canine area than on her right. And the way I can transmit this information is, open wide for me, is to again place her treatment prosthesis in and take a centric relation record, and then the laboratory technologist, bite down, can place the teeth exactly where I want them, because he'll have a cast of the maxillary and mandibular denture and be able to mount it up. Now, what we'll do is take some centric relation, polyvinyl siloxane material, place it in the mouth, and for want of a better term, we romance the condyle. Relax your jaw and close. The bite is good on this, so I don't have to worry about holding it. Just stay closed for me, and we wait for 2 minutes. Stay closed. Okay, we're done, and I've had Joyce open here, and notice that the centric relation material here is stuck to the existing denture. So I take it out gently, and you can see that it's very accurate. And with this and the cast of this treatment prosthesis, I give the information to the laboratory technologist to be able to make and set the teeth up exactly where I want them. It's very important to communicate with your laboratory technologist. And when I tried in this denture with the teeth in wax, I noticed that the teeth were arranged in more of a class 1 occlusion, which a lot of people would just ordinarily do. However, in Joyce's case, I arranged her teeth more in a class 2 occlusion because it looks better and it also functions better for her speaking. So what I did was make impressions of her existing treatment prosthesis, pour it up into a cast. Then I was able to take a centric relation record in her mouth, and this will be mounted on this same articulator so that I can communicate with the laboratory technologist exactly the way I want it done. In this case, we will have to probably take these two bis out here, these two premolars, first premolars. Leave these alone, these three, because the occlusion is good, the vertical dimension of occlusion is good, but pull back the anteriors to make it work so that they're not too far back. And I like the idea of a premolar and two molars. There's less of a balancing effect in the back. You don't have a cantilever that's too far, although we are extending to the retromolar pads. And and the literature shows that you need to have 2/3 of your retromolar pads covered. These areas here are fixed. They're muscle insertion attachments, and they never move throughout the life of a patient. So you have a tripod. But I want the teeth back farther for aesthetics and phonetics. And this is how I convey that. It's a real simple thing to do, and then you don't have to have 3 or 4 different try-ins because that technologist doesn't really know what the patient looks like. And I place this prescription all on the prescription pad. So not only does he have the cast, the centric relation record, all going to be mounted, he has this in writing. Reset teeth in wax to duplicate treatment prosthesis. Because I put a lot of time in to make sure this looks good and feels good to her. And I say I have it in a class 2 arrangement, probably remove first premolars for room. So what we'll do is make another appointment for Joyce for a try-in in wax again. It won't take long, but it's a very important try-in. Don't just skirt the issue thinking that the lab technologist is going to do it perfectly. It may not quite be right in the mouth. Then, in the next appointment, with the last try-in in wax, I can work behind her with my Bunsen burner and wax spatula and tweak some things a little bit. But I can't do that with this. This is too much work. Okay, Joyce, we're going to try in this denture with the teeth in wax right now. You remember we tried it in last time, and it wasn't quite right. We didn't like not only the look, but some of the occlusion sequence. So I was able to tell the laboratory technologist through the model or the cast of this treatment denture that we had made, of course, and it doubled as a radiographic guide. And we were able to do a centric relation record, and then they were able to duplicate it. So we're going to try that in again, okay?
Okay.
Kind of clicks down right where the two attachments are placed. Bite down for me. Tap, tap, tap. Good. And go side to side, slowly, and out. Bite down on your teeth, and just slide out. Try that again. Slide out slowly. Very good. This is very, very close to being in bilateral balance position in her occlusion. It's very important so that the maxillary denture doesn't flop out when she's chewing in her Posselt envelope. And it's important that the lower also, the mandibular, doesn't flop around at all either. Even though we've got 4 attachments right here, the posterior area isn't on an attachment. It's on the retromolar pad, which is also very stable, but it doesn't necessarily have retentive features. So this is very close, and when this is processed, open for me, I can bilateral balance this very, very rapidly with a remount relation record and go ahead and reset the teeth on the articulator, the mold, the cast. So this is in great shape, and now it's ready to process. And when we do process this, we will have all 4 attachments in here, actually in the acrylic, because this is an occlusion rim and wax on the outside. No, it's not the permanent one. She's keeping things really clean right now. I mean, they're in good shape. Definitely integrated. Her treatment denture has a little sore spot, and it's on her right side, on the buccal area, and I can see a little white area that's bothering her, and it's right there on her external oblique. And what we're going to do is adjust that. A lot of times I'll use pressure indicating paste, but in this case, because I can see it, I'll probably just eyeball it. And there it is, right below the third radiographic guide mark. Isn't that cool? Okay, we'll take it off. Just adjusted it a little bit. And what I'll do now is polish it with a rag wheel and pumice. So I'm going to try it in again and see how it feels for you, okay? Mm-hmm. There's the mark. And I think I got it. Mm-hmm. Good, good. And obviously if you have a little sore spot the next time you come in, we'll continually adjust it a little bit because, you know, you need this, you never know. We can use it as a spare too later on. Mm-hmm. So here we have her treatment prosthesis, and here we have the one in wax. And the treatment prosthesis is so important because the patient wears it for quite a long time and it's very comfortable. Well, obviously then you can go ahead and duplicate it, the look as well as the aesthetics and the phonetics. And your next appointment will be the insertion of the permanent prosthesis, okay? We may need to do some adjustments with the bite, so to speak, to make the occlusion bilaterally balanced in the excursive and protrusive movements, okay? Mm-hmm. This is TheraSpray, and it's made by 3M Espy. We like it a lot with people who don't have as much saliva for many reasons. Drug therapy, people who take certain drugs, they lose their saliva flow. Some people have Sjogren's syndrome and don't have any saliva. Some people, as they get older, just have a lack of saliva. We really like this TheraSpray, and it's, you know, a couple little zips in the mouth like you've been doing, Joyce, mm-hmm. and it creates a nice artificial saliva for a long time. There's another one called Biotine, and that's very good too. I'm sure yes. You've used it.
I have a bottle of it.
Good, good. And we carry the kit in our office for our patients who have a lack of saliva. It's very, very good. Good idea, Joyce. Joyce, we're in a very nice day today because we're going to try to insert this prosthesis, okay? And it has the 4 attachments in it mm-hmm. that clip on to the 4 implant attachments themselves. Mm-hmm. That allows for great retention, and of course you can hear this, snaps on real nicely. Right. You still may get some sore spots, especially in the posterior areas. That's the nature of the beast, and we'll be seeing you periodically, for sure tomorrow, and then possibly you know, early next week, okay? I want to take this lower out and just show you the difference. You can see how clean the new one is. It doesn't have a soft liner in it, although that soft liner worked very well during our yes, transitional period, didn't it? Yeah. Mm-hmm. So, and you don't need as much of an extension because these attachments in here, these O-ring attachments, really create more retention than anything that I can do as a regular denture. Mm-hmm. In this case, we had the lingual flange pretty far down into the lateral throat form. You have a lateral throat form that is conducive to this, but it's not needed when we do place the attachments, okay? So we'll just check these guys out. Not too bad, not too bad. This very right one has a little bit of calculus on it, and we'll get that off with a plastic scaling instrument, okay? Mm-hmm. You never want to have anybody use a metal instrument on these implants or the abutments, okay? So what I'm going to do, Joyce, is just kind of take off some more plaque than calculus. But what that means is that and it's just on this one abutment that you have a little bit of plaque and calculus, mostly plaque around the gingiva, or mucosa, I should say. And there's a little bit on this one here as well, but not bad at all. So you can brush this right one as best you can. I know you have a little problem because you only have one hand to deal with, but you can move it around.
On that side.
Yeah, yeah. That looks pretty good. Not bad. I give it a B. But not bad. I mean, I've seen them where you can't even get the prosthesis on there. So much calculus on these. And a lot of it is from your saliva ducts right here. They're called Wharton's ducts, and they're right behind these, and they bathe these implants and the abutments continuously. And there's amylase in that saliva, and so it has a tendency to stick. So we'll go ahead now and place the prosthesis. And the way that I want you to do it, and we'll practice it many times, is when you put it in your mouth, you know, kind of move it around a little bit and always place it with your fingers. Did you hear that noise? Pretty neat, huh? Don't ever clamp down on it with your upper prosthesis, all righty? Bite down for me. And you can see the borders are pretty darn good. Check out that might have to be adjusted. The little PIP, pressure indicating paste, or border molding paste. But not bad, not bad. And just kind of stay there. Do me a favor and lick your lips. I know you're pretty... Why don't you use your spray, TheraSpray. That's good stuff, by the way. Good. Get that saliva flow going. Good. And do me a favor and say Mississippi.
Mississippi.
66.
66.
Very good. Bite down. Very good. Now, what I want you to do is slowly, with your teeth together, slide your lower jaw to the right side over here. Good. Now, do it again on the left side. Good. Very good. What we want in this case is what we call bilateral balancing occlusion. It's very important. The reason is that we don't want the upper denture to flop around and we don't want the lower denture to pop up too. That's one of the reasons for sore spots. It's also one of the reasons for resorption and just all-out discomfort. So what we'll be doing today is checking the bite and doing some fine-tuning. It's very close. It's really close, so I think I can just do some little adjustments and we can make sure it's bilaterally balanced. If it takes more adjustments, then what we have to do is do a remount procedure and take your bite in all the eccentric relation as well as the excursive movements and put it on an articulator, which is a simulator of your jaw, and then we can fine-tune it on an articulator. Okay? And you remember that from previous. So we're going to go ahead and just kind of bite down, tap, 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 keep tapping, open, and bite down, tap, 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 open. Our centric relation marks are pretty close. That's basically how I would want to see it, with just nary a mark on those four anteriors, but I certainly like them on the posteriors as much as I can, and get a little bit of a mark on the anteriors. And tap, tap, tap on your back teeth. Tap, tap, tap. Keep tapping. Open. And we've got some brush marks here on the anterior. I really like that. I don't want to overload the implants, but I do want some support in the front. What we don't want, and this can happen, is get what we call a combination syndrome, where there's too much pressure placed on the upper denture in the anterior section, causing resorption in the anterior, and it creates the upper denture to come up, the lower denture to come up, and then we have a combination syndrome. So we have to make sure, bite down for me again, that the posteriors touch very nicely in the right plane of occlusion, which is your Frankfurt plane. Okay? Bite down. Good. We'll let that sit for a little while, and we'll see if we get any sore spots that I can see or that you can tell me. Joyce, we've waited a few minutes, maybe more like 10 or 15 minutes. Do you have any spots that might be a sore spot? Okay, in that area there. I'm going to take a look. We should have a little red mark. If so, then I can just use a marker, purple marker. Yeah, I see it. It's right there. I think I see 2 spots. So what I'm going to do is mark the 2 areas. One area is right here. It's a very accurate way. It transfers the blue mark onto the prosthesis. And then you don't have to... There's a little area right here. And you can see that within about 15 minutes, so don't let the patient just go out. It's important to have these areas pretty much rectified on the first appointment. Okay? I can do a little better on this guy. Yeah, there we go. Stay real still. And I'll place this back in very carefully. It should come right out. Then you can see the marks are very accurate. You certainly don't want to hollow out all kinds of stuff, because accuracy is the intaglio surface of this prosthesis. And do our best just to stay within where the marks show. Very accurate. Don't overdo it. You usually don't need to. You can usually see where the area is that was a little high in the intaglio surface. And a lot of times it's from the processing. The acrylic sometimes stays in that area, but it could have been from the impressioning. You just don't know. Then we clean it off, and we settle it in, and it clicks right in. Bite down. Is that feeling a bit better? Are we getting that sore over here still?
No, not
Just-
with it in.
just-
It scrapes it.
Just when it's taken out. Okay, we're going to let you take it out without letting it be scraped, because obviously I can't feel it. And yeah, just do that. So that didn't bother you, did it?
Mm-mm.
Okay, now being that you only have the use of one arm, let's put it back in, but be very gentle and just place it on gently. That's it, just like that, just knowing where it's at, and then use your 2 fingers like this to place it in on either side. How's that? Good. And you got that all the way down before you bit on it.
Yes.
Good. That's very important. You never want to bite that in with the denture.
Snap,
Oh, that's okay.
that one is the one that snaps in.
Right,
Really
right.
good.
And bite down. Tap, tap, tap. Good. That will change the bite a little bit because it settles down. Okay, it settles a little bit because those 2 spots were a little high. So I'm going to check your occlusion again, okay? Your bite. Tap, tap, tap. Keep tapping. Open. Tap, tap, tap. Open. The reason why I go ahead and tap, 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 do one side at a time, I can hear what side might be hitting first. I can actually hear it, and you're doing very well. Close for me. Lick your lips. Say Mississippi.
Mississippi.
Very good. 66.
66.
Good. You're not hitting your teeth when you're saying that?
Yes, I am.
A little bit in front.
These
Uh-huh. Mississippi.
Mississippi.
Not bad. And just say 66.
66.
Not bad. I like that.
They
A little bit.
touch here a little.
You go forward quite a bit, though, when you're saying that. Bite down for me. That's good. So I'm not worried about that too much.
I notice in eating pizza,
Uh-huh.
I can't seem to bite exactly.
With the old ones.
Yeah.
We'll see how these are. But you need to know pizza's a tough cookie.
Yeah.
That's like steak. And it doesn't give so much. But, you know, you can try that a little bit later. What I would suggest doing is trying a little softer foods first to get used to these, like maybe hamburger patties, eggs, things like that. Soft chicken to start with, and then if you feel game,
Well, I usually
cut it up.
cut everything.
Good, good. This you won't have to so much, but still, these are both dentures, and they're on soft mucosal tissue.
Right.
So something has to give, and guess what usually does? Your soft mucosa. But this is a whole lot better. When you open real wide, you can see open. Nothing moves.
Right.
And that's because of those 4 attachments in your denture, as well as the balls on the implants.
Right.
So I think the best thing for us to do is to let you go, let things settle in, and we'll see you tomorrow. And we can go ahead and institute anything that we need to do with our occlusion, as far as bilateral balancing occlusion and everything. And sore spots first, of course, because that changes things a little bit. Okay? But I think you're in good shape. Go ahead and take them out again for me, Joyce. Just the lowers. Do that, yeah, with your fingers. You won't be able to do that with your tongue so much now, and that might be a problem by lifting it forward. Okay, now put it back in very carefully and let them settle in with your, that's it, fingers. Here, I heard it.
I did.
I heard it snap. Very good. Okay,
Okay.
we're in good shape. You look great. We got a nice overlap so that your lowers don't look too bulky. You know, like the Washington look, we don't want that. And the Washington dollar bill look. And we want your top teeth to show a little bit as well. Okay? Joyce, this is a little kit that we give all of our patients who have prostheses that have to go in and out of the mouth. And it's a really good start to keeping things really clean, okay? So I'll just put this right here. The first thing is the bath. And you put your prosthesis inside, and what I'll do is take this one out. Of course, I'm not as good as you are now taking it out, so I'll be hurting you, of course. And you put the denture like in this position, have some water in it, and already have some of these Fixodent denture cleaner tablets, pop, pop, fizz, fizz.
Right.
And that's already been done, and then you put that in there. And these are some examples of that. And then after you've done that, then you can use this brush, which is a really nice ergonomically developed denture brush, and you're able to then clean it under warm water and get some of these out right in here. Some of the you have to be able to see to get some of the food and stuff out of these little holes, or else it won't go down right.
Right.
Okay, and then the top, you can go ahead and brush with the larger brush and keep it really clean, okay? Needs to be clean. And then you'll need to come in every 3 months for cleanings. And when that happens, obviously you bring a denture in, and then we can clean it in our ultrasonic and make sure you're doing a good job. Okay? Also inside of this little kit is a little bit of fixed dent. That's for your purse, take-home stuff for your purse, and of course the big one that you might have for your maxillary denture if you need it, you would have at home. I don't necessarily recommend using fixed dent on this lower now because of the implants that you have there.
I don't need it.
No, you don't. And this has some nice little examples for at CVS, Walgreens, or Rite Aid to get some stain away plus. And you can get all this stuff at the drugstore, okay? So that'll allow it to be really clean. And that's for you.
Thank you.
My pleasure. Let me put this back in. I always recommend having it a little wet when you put it in. And again, you just kind of get it to where it settles on top and press down, and you can hear that click, and it works out really well. Very good.
Very good.
Well, you're set.